I've been a speech-language pathologist at St. Catherine's Medical Center for 14 years, specializing in communication disorders and rehabilitation therapy. My work involves helping patients regain speech abilities after strokes, traumatic brain injuries, and various neurological conditions. I'm trained to assess communication capabilities, identify language patterns, and develop therapeutic interventions for patients who have lost the ability to speak. Eleanor Vasquez taught me that sometimes patients don't regain their original language. They discover languages they never learned. Eleanor was admitted to our neurological intensive care unit following a severe stroke that affected the left hemisphere of her brain, specifically Broca's and Wernicke's areas, the regions responsible for speech production and comprehension. At 67 years old, she had been a retired elementary school teacher who spoke only English and basic conversational Spanish. The stroke left Eleanor completely aphasic, unable to speak, write, or comprehend language in any meaningful way. This is unfortunately common with her type and location of brain injury. Dr. Martinez, her neurologist, referred her to my department for communication assessment and potential rehabilitation therapy. During my initial evaluation, Eleanor responded to simple gestures and showed awareness of her surroundings, but produced no verbal responses. She would open her mouth as if attempting to speak, but no sounds emerged. Her family confirmed that she had never studied Latin, classical languages, or demonstrated any interest in ancient texts or religious studies beyond attending Sunday Mass at their local Catholic church. Eleanor's recovery followed a typical pattern for the first 2 weeks. Gradual improvement in alertness, some response to basic commands, occasional attempts at vocalization that produced only unintelligible sounds. Her family visited daily, speaking to her in English and Spanish, hoping to stimulate language recovery through familiar voices and conversations. On Thursday morning during my 3rd week of working with Eleanor, something unprecedented occurred during our therapy session. I was conducting routine exercises, asking Eleanor to attempt simple word repetitions, when she suddenly began speaking clearly and fluently. But she wasn't speaking English or Spanish. Pax vobiscum, filia mea. Tempus est ut veritas revelatur, Eleanor said, her voice strong and confident. I recognized the cadence and structure as Latin, though I couldn't understand the specific meaning. Eleanor continued speaking in what appeared to be fluent Latin for approximately 5 minutes, gesturing expressively as she spoke, maintaining eye contact, and pausing as if expecting responses to her statements. When she finished speaking, Eleanor looked at me expectantly, as if waiting for my reply in the same language. Eleanor, I said in English, I don't understand Latin. Can you speak in English or Spanish? She tilted her head with apparent confusion, then repeated her original statement, Pax vobiscum, filia mea. Tempus est ut veritas revelatur. I documented this extraordinary development and immediately contacted Dr. Martinez. Patients with aphasia sometimes experience temporary improvement in language abilities, but Eleanor had never demonstrated knowledge of Latin before her stroke. Could this be some form of confabulation? Dr. Martinez asked, referring to the neurological phenomenon where patients create false memories or information to fill gaps in their recollection. It's possible, but the Latin sounds grammatically consistent and purposeful. She's not just producing random sounds, she's constructing what appears to be meaningful sentences. We decided to consult with Father Michael O'Brien, our hospital chaplain who had studied Latin during his seminary training. Father O'Brien was intrigued by Eleanor's case and agreed to sit in on my next therapy session. The following day, Eleanor again began speaking in Latin as soon as I entered her room. Father O'Brien listened carefully, taking notes and occasionally nodding with recognition. She's reciting prayers, he told me afterward. Not just standard Catholic prayers, but older liturgical texts, some from medieval period devotional practices. The Latin is quite sophisticated, using grammatical constructions that suggest advanced study. Is it possible she learned these prayers at some point and is now accessing those memories? Father O'Brien shook his head. The prayers she's reciting aren't commonly known, even among clergy. Some of the texts she's using are from manuscripts I studied in seminary but haven't encountered in modern liturgical practice. I decided to record Eleanor's Latin sessions to facilitate translation and better understand the content of her communications. Using a digital recorder, I documented a 30-minute session where Eleanor spoke continuously in Latin, varying her tone and inflection as if engaged in conversation with multiple people. When I reviewed the recording later that evening, I discovered something deeply unsettling. Eleanor's voice was clearly audible throughout the recording, but there were additional voices, faint but distinct, that seemed to be responding to her. Statements in Latin. These other voices hadn't been audible. During the actual session, I played the recording for Father O'Brien the next day. He listened with growing concern, translating fragments as the audio progressed. She's asking questions about the spiritual preparation of souls who are transitioning between life and death, he said. And these other voices, they're providing answers, giving guidance about prayers and rituals that help souls navigate what she calls the threshold places. But I only heard Eleanor speaking during the session. These other voices weren't present in the room. Father O'Brien replayed sections of the recording, isolating the additional voices. This voice sounds like an elderly woman, possibly speaking ecclesiastical Latin with a regional accent I can't identify. This one sounds younger, maybe male, using more modern Latin pronunciation. Are you saying there are other people speaking on this recording who weren't physically present? That's exactly what I'm saying. And based on the content of their conversation, they seem to be instructing Eleanor in prayers and spiritual practices that aren't part of standard Catholic liturgy. Over the following week, Eleanor's Latin sessions became more complex and frequent. She would speak for hours, pausing to listen to responses that only the recording equipment could capture. The conversations, according to Father O'Brien's translations, focused on spiritual guidance for people who were dying or had recently died. She's being taught to serve as a spiritual translator, Father O'Brien explained after reviewing several recordings. The voices are instructing her in prayers and rituals that help dying patients prepare for whatever comes next. But Eleanor has never been religious beyond basic church attendance. Why would she suddenly become some kind of spiritual intermediary? According to the conversations on these recordings, her stroke didn't just damage her speech centers. It opened what they call threshold perception. She can now communicate with spiritual entities who assist people during the dying process. Eleanor's family was disturbed by these developments. They wanted their mother to recover her normal speech, not develop abilities that seemed supernatural and frightening. This isn't the woman we know, her daughter Carmen told me. My mother was a practical person. She taught third grade for 30 years. She didn't speak Latin and she wasn't interested in mystical experiences. But Eleanor seemed content and purposeful during her Latin sessions. Her overall health was improving, and she showed no signs of distress or confusion about her new linguistic abilities. 3 weeks after the Latin sessions began, Eleanor started incorporating her new skills into patient interactions. She would visit other rooms on the neurological unit, speaking Latin prayers with patients who were terminally ill or dying. The nursing staff reported that patients seemed comforted by Eleanor's presence, even though they couldn't understand her words. Families noted that their dying relatives appeared more peaceful after Eleanor's visits. It's like she's providing some kind of spiritual service, observed Nancy Chen, one of our veteran nurses. Patients who were agitated or frightened seem to calm down when she speaks to them in Latin. Dr. Martinez was concerned about Eleanor wandering the unit without supervision, but her family requested that she be allowed to continue her patient visits. If this is helping other people, and it seems to be helping her recovery, maybe we shouldn't interfere, Carmen decided. Eleanor remained at St. Catherine's for 2 more months, serving as an unofficial spiritual counselor while her physical recovery progressed. She regained some basic English vocabulary but preferred to communicate in Latin, especially when discussing anything related to illness, death, or spiritual matters. Her recordings continued to capture multiple voices providing guidance and instruction. Father O'Brien eventually stopped trying to translate all the conversations, reporting that the spiritual content was becoming too complex for his theological background. They're teaching her things that aren't in any seminary curriculum, he admitted. Prayers and practices that seem to come from much older traditions, possibly pre-Christian or from mystical branches of Christianity I've never encountered. Eleanor was discharged to a rehabilitation facility in December, still speaking primarily Latin, still serving as a spiritual translator for patients who were approaching death. Her family had adapted to her transformation, recognizing that while they had lost the mother they remembered, they had gained something equally valuable, a person who could provide comfort in ways they didn't fully understand, but couldn't deny were meaningful. 6 months after her discharge, I received a call from the rehabilitation facility. Eleanor had passed away peacefully in her sleep, speaking Latin prayers until her final breath. The nursing staff reported that her room had been filled with what sounded like multiple voices responding to her prayers, creating a kind of spiritual chorus that continued for several minutes after Eleanor herself had stopped speaking. The facility's recording equipment, running for documentation purposes, captured only silence during Eleanor's final moments. But everyone present insisted they had heard the voices, not just Eleanor's, but the others she had been conversing with throughout her recovery, finally welcoming her into conversations that human technology could no longer detect or preserve. I've been the night shift charge nurse in the intensive care unit at Memorial General Hospital for 16 years. In that time, I've witnessed thousands of medical emergencies, codes, and patient deaths. The ICU operates with predictable rhythms. The steady beeping of monitors, the whisper of ventilators, the controlled urgency of life support interventions. We maintain detailed documentation of every visitor, every medical professional, every person who enters our unit, because critically ill patients require strict monitoring and controlled access. The man in the dark suit violated every security protocol we maintained, yet he provided comfort to families in ways that our medical team couldn't achieve through conventional means. I first noticed him on a Tuesday night in October. Mrs. Davis in bed 7 was dying from complications following cardiac surgery. Her family had maintained a bedside vigil for 3 days, knowing that her condition was deteriorating despite our best efforts. Around 2:30 a.m., I was checking on Mrs. Davis when I noticed a tall man in a dark suit standing beside her bed. He wasn't anyone from our medical staff. Our ICU team consists of 12 physicians, 15 nurses, and 8 respiratory therapists, and I know every face that belongs in our unit. This man was distinctly different, approximately 6 feet tall, thin build, wearing a well-tailored dark suit with a white shirt and conservative tie. His hair was dark, neatly styled, and his demeanor was calm and professional. "Excuse me," I said, approaching the bedside. "Are you a family member?" Visiting hours ended at 9 p.m. The man looked up from Mrs. Davis and met my eyes with an expression of gentle authority. "I'm here to help with the transition," he said quietly. "Mrs. Davis will be more comfortable now." Before I could ask what he meant or request identification, he walked past me toward the ICU exit. I followed him, but by the time I reached the hallway, he had disappeared. The ICU has only one entrance and exit, monitored by security cameras and badge access controls. No one could leave without being recorded. I returned to bed 7 and found Mrs. Davis's family gathered around her bedside, all of them appearing remarkably peaceful despite their mother's critical condition. The doctor who just visited was very helpful, Mrs. Davis's daughter told me. He explained what we could expect and assured us that Mom wouldn't be in pain. "What doctor?" "The tall gentleman in the dark suit. He said he was part of the palliative care team. He spent several minutes with us, answering questions and helping us understand the process." I knew our palliative care team personally. None of them matched the description of the man I had just encountered, and none were scheduled for night rounds. Mrs. Davis coded at 2:47 a.m., 17 minutes after the mysterious visitor's departure. Despite our resuscitation efforts, she passed away at 3:12 a.m. Her family remained calm throughout the emergency, expressing gratitude for the preparation they had received from the unknown doctor. I documented the visitor incident in my shift notes and reported it to security. They reviewed the camera footage from the ICU entrance, the hallways, and the elevators. No one matching the man's description appeared on any recording between 2 a.m. and 3 a.m. "Are you certain someone was there?" asked Tom Harrison, our security supervisor. Mrs. Davis's family spoke with him extensively. They can describe his appearance, his voice, even specific things he said to them. Tom pulled up additional camera angles, checking every possible route into or out of the ICU. According to our security system, only authorized personnel entered the ICU during that time period. No unidentified visitors, no one in a dark suit. 3 nights later, I encountered the same man again. Mr. Peterson in bed 12 was dying from complications of COVID-19. His family couldn't visit due to isolation protocols. and he was alone except for our medical staff. Around 1:15 a.m., I noticed the tall man in the dark suit standing beside Mr. Peterson's bed. "Sir, you can't be in here," I said, approaching quickly. "This is a COVID isolation room. You need protective equipment." The man looked at me with the same calm expression I remembered from our previous encounter. "Mr. Peterson needed someone to sit with him," he said. He was afraid of being alone. "Are you family? How did you get past security?" "I'm here to ensure he transitions peacefully. That's my role in these situations." I called security immediately, but by the time Tom Harrison arrived, the man had vanished again. Mr. Peterson coded at 1:34 a.m. and passed away despite our intervention efforts. After Mr. Peterson's death, I spoke with Dr. Jennifer Martinez, who had been his attending physician. "Did you notice anything unusual about Mr. Peterson's final moments?" "Actually, yes," she replied. "Despite being on maximum ventilator support, he seemed remarkably peaceful in his final hour. His vital signs showed less distress than we typically see with COVID patients. It was as if he felt accompanied." Over the following month, I documented 6 more appearances by the mysterious visitor. Each time he appeared beside patients who would die within 30 minutes of his arrival. Each time, families or patients reported feeling comforted by his presence, describing him as a doctor or chaplain who provided spiritual guidance and emotional support. The pattern became so consistent that I started watching for him as a clinical indicator. When the man in the dark suit appeared, I knew to prepare for an emergency code and to notify families that their loved one's death was imminent. Dr. Patricia Wong, our ICU director, was skeptical of my reports until she witnessed the phenomenon herself. She was completing late evening rounds when she noticed the man standing beside Mrs. Thompson in bed 4. I assumed he was a family member who had been given special permission to stay past visiting hours. Dr. Wong told me later, but when I approached to discuss Mrs. Thompson's condition, he introduced himself as a transition counselor. What did he say exactly? He said he was there to help Mrs. Thompson and her family understand the process of letting go. He spoke with remarkable knowledge of her medical condition and prognosis, using appropriate medical terminology. He seemed to know details about her case that weren't immediately apparent from bedside observations. "Did you ask for his credentials?" I did, but he deflected the question, saying he was part of a special program that provides end-of-life counseling. Before I could pursue it further, Mrs. Thompson's daughter asked me about pain management, and when I turned back, he was gone. Mrs. Thompson died 22 minutes later. Dr. Wong reviewed the security footage with Tom Harrison, focusing on the time period when she had observed the visitor. Like all previous incidents, the cameras showed no evidence of anyone matching his description entering or leaving the ICU. "This is medically impossible," Dr. Wong said. "Either we have a significant security breach or we're experiencing some form of shared hallucination among staff and families." "The families are very specific in their descriptions," I pointed out. "They remember detailed conversations, specific advice he provided, even his exact words in some cases. That's not consistent with hallucinations. We decided to implement additional security measures, extra cameras, badge readers at multiple checkpoints, and security personnel stationed specifically to observe the mysterious visitor. For 2 weeks, the ICU was monitored more intensively than any unit in the hospital. The man in the dark suit continued to appear. Security cameras never recorded his presence, but families continued to report detailed interactions with him. Staff members observed him regularly, always in the same professional attire, always providing the same calm, comforting presence to dying patients and their families. Lisa Chen, one of our most experienced ICU nurses, decided to engage him in extended conversation during one of his visits. She found him beside Mr. Rodriguez in bed 9, speaking quietly with the patient's wife and adult children. "Excuse me, doctor," Lisa said. "Could I speak with you about Mr. Rodriguez's care plan?" The man nodded politely. "Of course. Mr. Rodriguez is transitioning toward the end of his current journey. His family needs to understand that this is a natural process, not a failure of medical intervention. Are you part of our palliative care team?" "I serve in a consulting capacity for patients who require specialized transition assistance. My role is to ensure that families understand the process and that patients feel accompanied during their final moments." Lisa asked specific questions about Mr. Rodriguez's condition, medications, and prognosis. The visitor answered with detailed medical knowledge that indicated extensive training in critical care and end-of-life management. "What medical school did you attend?" Lisa asked. The man smiled gently. "My training was quite specialized, focused on the intersection between medical care and spiritual transition. Not all education follows traditional institutional paths. Could you provide me with your credentials for our records?" "My authorization comes from a different system than your hospital's administrative structure. But I assure you, my presence here is both necessary and beneficial for the patients I visit." Mr. Rodriguez died 38 minutes after this conversation. His family later told Lisa that the mysterious doctor had prepared them perfectly for their father's death, providing specific guidance about what to expect and how to support each other through the grief process. Dr. Wong eventually consulted with colleagues at other hospitals inquiring about similar unexplained visitor phenomena. She discovered that 3 other major medical centers in our region had documented identical cases. A tall man in dark professional attire who appeared beside dying patients, provided comfort to families, and never appeared on security footage despite detailed witness accounts. "It's always the same description," reported Dr. Susan Kim from City General Hospital. "Same appearance, same professional demeanor, same timing relative to patient deaths. Families consistently describe feeling grateful for his presence and guidance." "Have you found any explanation?" "None that makes medical sense. But the correlation between his appearances and peaceful patient deaths is statistically significant. Patients he visits seem to experience less distress during the dying process, and families report better emotional outcomes following their loss." I've continued documenting the mysterious visitor's appearances for the past 2 years. He maintains his regular presence in our ICU, arriving without explanation and departing without trace, providing comfort that our medical protocols can't replicate and preparing families for losses in ways that our training doesn't teach. The man in the dark. Suit has become an unofficial member of our end-of-life care team. While we can't explain his presence or document his credentials, we've learned to appreciate the service he provides. Families feel less alone, patients seem to die more peacefully, and the transition from life to death occurs with a dignity and preparation that purely medical intervention rarely achieves. We no longer report his appearances to security. Instead, when I see the man in the dark suit standing beside a patient's bed, I know that death is approaching, and I prepare our team accordingly. I also know that the family will receive guidance and comfort from someone whose qualifications exist beyond the boundaries of conventional medical training. Sometimes, the most important members of our healthcare team are the ones who can't be documented, credentialed, or explained through standard protocols. Sometimes healing requires the presence of individuals who understand transitions that medical education doesn't address and who provide services that exist in the spaces between life and whatever follows. The man in the dark suit continues his work, ensuring that no one dies alone and that families receive preparation for losses that can't be prevented, but can be made more bearable, through the presence of someone who understands the process better than any of us who remain bound by the limitations of purely medical knowledge. I've been practicing internal medicine at Valley Community Hospital for 11 years, and I've always prided myself on meticulous documentation. Patient charts are legal documents, requiring precise notation of symptoms, treatments, and outcomes. Every entry I make is carefully considered, accurately timed, and properly attributed to ensure continuity of care and legal compliance. The case that shattered my confidence in the reliability of medical records began with what appeared to be a simple documentation error in my own handwriting. Mrs. Helen Carter was admitted to my service on a Monday morning with pneumonia. A straightforward case for a 74-year-old woman with no significant comorbidities. Standard treatment protocol: chest x-ray to confirm the diagnosis, blood cultures to identify the bacterial pathogen, and empiric antibiotic therapy while awaiting culture results. I examined Mrs. Carter at 10:30 a.m. and documented my findings in her electronic medical record. Patient presence with productive cough, fever, and shortness of breath. Physical exam reveals decreased breath sounds in right lower lobe. Chest x-ray confirms right lower lobe pneumonia. Plan: blood cultures, sputum culture, start ceftriaxone 1g IV daily. That afternoon, I reviewed Mrs. Carter's chart to check on her response to treatment. Her progress note: The one I had written that morning had been modified. The text now read, "Patient presents with productive cough, fever, and shortness of breath. Physical exam reveals decreased breath sounds in right lower lobe. Chest X-ray confirms right lower lobe pneumonia. Plan, blood cultures, sputum culture, start ceftriaxone 1g IV daily. Note, patient will develop allergic reaction to ceftriaxone at approximately 4:30 p.m. Recommend switching to azithromycin, 500 mg IV daily, and administering diphenhydramine, 25 mg IV for reaction management." The handwriting was unmistakably mine. Same pen pressure, same letter formation, same abbreviation patterns I had developed over years of clinical practice. But I had no memory of writing the additional text about an allergic reaction that hadn't occurred yet. I checked the electronic system logs to see who had accessed Mrs. Carter's chart and when modifications had been made. According to the computer records, only I had opened her file, and no edits were recorded after my original 10:30 a.m. entry. At 4:27 p.m., I received a call from Jenny Morrison, Mrs. Carter's nurse. "Dr. Williams, Mrs. Carter is having an allergic reaction to the ceftriaxone. She's developed hives and is complaining of itching. What would you like me to do?" I stared at Mrs. Carter's chart on my computer screen, reading the allergic reaction prediction I apparently had written but didn't remember writing. "Discontinue the ceftriaxone immediately. Give her diphenhydramine 25 ml IV and start azithromycin 500 ml IV daily. I'll get that started right away." Mrs. Carter's reaction resolved quickly with the treatment modifications, exactly as outlined in the mysterious addition to my progress note. Her recovery proceeded without complications, and she was discharged 3 days later with oral antibiotics. I spent considerable time trying to rationalize what had happened. Could I have written the additional text and forgotten about it? Had I somehow predicted Mrs. Carter's reaction based on subtle clinical indicators I had processed subconsciously? Neither explanation felt satisfactory. I had no clinical reason to suspect Mrs. Carter would react to ceftriaxone. She had no documented drug allergies, and her reaction was not typical for her demographic group. 2 weeks later, I encountered a similar situation with Mr. David Thompson, admitted for diabetic ketoacidosis. I documented his treatment plan at 8:15 a.m. Standard insulin protocol, fluid resuscitation, and electrolyte monitoring. When I checked his chart that afternoon, additional text had appeared in my progress note. Patient's potassium levels will drop precipitously around 2 p.m. despite normal replacement protocol. Increase potassium supplementation to 40 μq in 1000 ml, normal saline, and monitor levels every 2 hours. Again, the handwriting was identical to mine, but I had no memory of writing those instructions. At 2:15 p.m., laboratory called with critical values. Mr. Thompson's potassium had dropped to 2.1, a dangerously low level that required immediate intervention. I ordered the exact treatment outlined in my mysteriously modified progress note. I began paying obsessive attention to my documentation, photographing my progress notes with my phone immediately after writing them to create timestamps and evidence of original content. Despite these precautions, modifications continued to appear. Over the following month, 6 of my patient charts were altered in similar ways. Each modification appeared in handwriting indistinguishable from my own. Each predicted complications or treatment needs that occurred hours later. Each time, the electronic system showed no record of edits or unauthorized access. Dr. Patricia Martinez, my department chief, became concerned when I requested a meeting to discuss unusual documentation anomalies. "Are you suggesting someone is altering your medical records?" she asked after I explained the situation. "I'm saying the records are being altered, but I can't identify who's doing it or how. The handwriting matches mine perfectly, and the system shows no security breaches. Could this be related to fatigue or stress? Sometimes physicians experience memory gaps when they're overworked." I showed Dr. Martinez the photographs I had been taking of my original notes compared to the modified versions. The differences were clear and undeniable. "This is highly irregular," she admitted. "We need to involve IT security and possibly contact the medical records department to investigate potential system vulnerabilities." The investigation revealed no technical explanations. Hospital IT confirmed that electronic medical records couldn't be modified without creating audit trails. Handwriting analysis experts confirmed that both the original notes and the modifications were written by the same person using the same pen and exhibiting identical writing patterns. From a forensic perspective, explained the handwriting analyst, these samples show no evidence of forgery or imitation. They appear to be written by the same individual, possibly at different times or under different circumstances. Sometimes handwriting variations occur due to stress, fatigue, or altered mental states. But these samples show remarkable consistency, suggesting they were written by the same person in similar conditions. Dr. Martinez consulted with colleagues at other hospitals to determine if similar documentation anomalies had been reported elsewhere. She discovered 3 cases of physicians experiencing identical chart modifications, accurate predictions of patient complications written in the doctor's own handwriting, with no memory of creating the additional content. Dr. Sarah Chen at Metropolitan General described exactly the same phenomenon. Dr. Martinez reported progress notes modified with her own handwriting, predicting patient outcomes with perfect accuracy, no system logs showing unauthorized access. What explanation did they find? None. The hospital administration classified it as an unresolved technical anomaly and implemented additional security monitoring. But the modifications stopped occurring after about 6 weeks. My chart modifications continued for 2 more months before gradually decreasing in frequency. The predictions remained completely accurate throughout this period. Medication reactions, complications, treatment needs that invariably occurred exactly as the mysterious additions to my progress notes described. The final modification appeared in the chart of Mrs. Angela Foster, an elderly woman admitted with heart failure. My original note outlined standard treatment protocols, but the modified version included detailed instructions for managing a cardiac arrhythmia that would develop during the early morning hours of the patient's 3rd day. Mrs. Foster developed atrial fibrillation at 3:20 a.m. on her 3rd hospital day, requiring precisely the intervention outlined in my inexplicably modified progress note. But this final chart modification included something different, a message apparently addressed to me directly. Dr. Williams will understand that some medical knowledge comes from sources beyond conventional training. These annotations represent guidance from physicians who have learned to practice medicine across different temporal boundaries. Trust the additional information. It will always serve your patient's best interests. The handwriting was unmistakably mine, but the content suggested knowledge and perspective I didn't possess. I never experienced another chart modification after Mrs. Foster's case. My documentation returned to normal patterns. Notes I remember writing staying exactly as I wrote them, with no mysterious additions or predictions. But I've kept detailed records of those 8 cases where my progress notes apparently wrote themselves, providing medical guidance that saved patient lives and prevented complications I had no way of predicting through conventional clinical assessment. Sometimes, I wonder if the modifications were messages from a future version of myself, somehow able to communicate backwards through time to provide critical patient care information. Or perhaps they came from other physicians who had learned to practice medicine beyond the normal constraints of linear time and medical training. Either way, I've learned to trust medical intuition more than I did before, to pay attention to subtle clinical indicators that might suggest developing complications, and to document thoroughly, even when the reasoning isn't immediately apparent. Because sometimes the most important medical knowledge comes from sources we can't explain, written in our own handwriting by hands that understand healing in ways we haven't learned yet. I've worked as a psychiatric nurse at Riverside State Hospital for 28 years, and I've learned that silence can be as communicative as speech. Patients choose not to speak for various reasons: trauma, medication side effects, catatonic episodes, or sometimes simply because they have nothing they want to share with the world that hospitalized them. Ruth Caldwell had been silent for 34 years when she finally chose to speak, and what she revealed challenged everything I understood about the relationship between time, death, and human consciousness. Ruth was admitted to our long-term psychiatric facility in 1987, diagnosed with catatonic schizophrenia following what her family described as a complete mental breakdown after her husband's sudden death. She was 32 years old at admission, physically healthy, but completely unresponsive to verbal communication, therapeutic intervention, or social interaction. For over 3 decades, Ruth maintained the same daily routine, She accepted personal care assistance without resistance, ate meals when food was provided, and participated in basic activities when directed by staff. But she never spoke, never initiated interaction, and never showed signs of improvement or deterioration. I was assigned to Ruth's unit in 1995, 8 years after her admission. By that time, she had become a fixture in our long-term care ward, a quiet presence who required minimal intervention and created no behavioral problems. Her chart showed consistent documentation. Patient remains mute, continues prescribed medications. No change in baseline functioning. Ruth's silence was so complete that new staff members would sometimes forget she was capable of speech. She had become part of the institutional landscape, like the worn chairs in the day room or the faded, motivational posters on the walls, present but essentially invisible. What made Ruth notable among our long-term residents was her apparent awareness of staff routines and schedules. Despite her lack of verbal communication, she seemed to track which nurses were working, when shift changes occurred, and how long individual staff members had been employed at the facility. She would position herself to observe nursing activities, following our movements with alert, intelligent eyes that suggested comprehension far beyond her documented cognitive assessment. During my early years working with Ruth, I made various attempts to engage her in conversation. I would sit beside her during quiet periods, describing my day, asking simple questions, trying to establish any form of communicative connection. Ruth would listen attentively, maintaining eye contact, but never responded verbally. "She understands everything," observed Dr. Helen Martinez, Ruth's psychiatrist for 15 years. "Her comprehension assessments are normal. Her problem-solving skills are intact when tested through nonverbal methods. She simply chooses not to speak." Have you ever found a trigger that might encourage verbal communication? We've tried various approaches: music therapy, art therapy, visits from former colleagues and friends. Ruth participates when directed, but never initiates verbal response. It's as if she made a decision 34 years ago to stop speaking and has never found a reason to reverse that decision. Ruth's care plan remained unchanged year after year. Medications were adjusted periodically, but her baseline functioning never varied significantly. She aged quietly and predictably, requiring standard medical monitoring for a woman in her 60s, but presenting no acute psychiatric or behavioral concerns. The night Ruth finally spoke began like any other routine shift. I was conducting evening vital sign checks, a standard procedure for all patients on our unit. Ruth was sitting in her usual chair by the window, looking out at the parking lot where night shift staff were arriving for their 11 p.m. start time. Blood pressure 128/82, I noted, removing the cuff from Ruth's arm. Pulse 74, temperature normal. As I was documenting her vital signs on my clipboard, Ruth turned to face me directly and spoke for the first time in 34 years. "Linda," she said quietly, her voice hoarse from decades of disuse. "Linda Morrison." March 15th, 2019. I stared at Ruth in complete shock. Linda Morrison had been a night shift nurse on our unit until her retirement 5 years earlier. March 15th, 2019, was the exact date of Linda's death from pancreatic cancer, information that hadn't been widely shared among current staff. "Ruth," I said carefully, "you just spoke. Can you tell me what you meant about Linda Morrison?" Ruth continued as if I hadn't interrupted. "Margaret Chen, August 3rd, 2017, Thomas Rodriguez, November 12th, 2020, Janet Parker, June 9th, 2018. Each name she recited was a former staff member from our psychiatric unit. Each date she provided was accurate. I knew this because I had attended some of their funerals and remembered others from obituary notices. "How do you know those dates, Ruth?" She looked directly at me with eyes that seemed suddenly focused and purposeful in a way I had never observed during her decades of silence. "Sarah Williams," she continued, and my blood went cold as she said my name. "October 7th, 2031. What are you telling me?" "The dates when each of you stops working here," Ruth said, her voice gaining strength and clarity. "Some retire, some transfer to other facilities, others transition more permanently." I sat down beside Ruth, trying to process what she was revealing. "Are you saying you know when people are going to die?" "I know when their service here ends. Time isn't linear for everyone, Sarah. Some of us experience it differently." Ruth continued reciting names and dates for the next 20 minutes. Current staff members, former employees, people I hadn't seen in years. She provided specific dates with absolute confidence, as if reading from a personnel roster that tracked every employee's eventual departure from Riverside State Hospital. Dr. Patricia Wong, May 22, 2025. Michael Stevens, February 14, 2028. Jennifer Adams, September 11, 2024. I recognized every name. Dr. Wong was our current unit director. Michael Stevens worked day shift security. Jennifer Adams was a psychiatric technician who had been hired just 6 months earlier. Ruth, how long have you known these dates? Since I arrived here. Time moves differently when you stop participating in the present moment. I've been observing from a position outside normal temporal flow. Is that why you stopped speaking? Ruth nodded slowly. When my husband died, I experienced a glimpse of how time actually works. Not as a straight line, but as something more complex, more layered. The psychiatric break wasn't a breakdown of my mind. It was an expansion of my perception beyond the boundaries most people experience. Why are you telling me this now? Because my time here is ending soon. Ruth Caldwell, November 30th, 2021. I checked my phone for the date. It was November 28th, 2021. You're saying you'll die in 2 days? I'm saying my service here will conclude in 2 days. Whether that means death or some other form of transition, I'm not entirely certain. But I wanted to share the information I've gathered during my years of temporal observation. Ruth spent the next hour providing detailed accounts of staff members' future departures. Some she described as retirements, others as job transfers, others as deaths from various causes. She spoke with remarkable knowledge of people's personal lives, medical conditions, and career plans that she couldn't have known through normal observation. How accurate are these predictions? I asked. Completely accurate for past events. I assume the same precision applies to future occurrences. I documented Ruth's unprecedented verbal communication in her chart, including the specific predictions she had made. Dr. Martinez was called to evaluate Ruth's sudden change in baseline functioning. This is extraordinary, Dr. Martinez said after spending an hour interviewing Ruth. Her cognitive function appears completely intact. Her speech is clear, her thought processes are organized, and her memory for institutional history is remarkably detailed. What about her predictions? I can verify that her information about deceased former employees is accurate down to specific dates. If her methodology is consistent, her future predictions might also be reliable. Ruth's transformation continued over her final 2 days at Riverside State Hospital. She spoke freely with staff members, answering questions about her decades of silence, sharing observations about hospital operations that demonstrated extraordinary attention to detail. I've been learning about time by stepping outside of it, she explained to Dr. Martinez. Most people experience time as a current that carries them forward moment by moment. But some traumatic events can shift a person's relationship with temporal flow, allowing them to observe from a position that encompasses past, present, and future simultaneously. Are you saying your husband's death caused this shift? His death opened a door in my perception. The psychiatric hospitalization provided a stable environment where I could explore that expanded awareness without external pressures to return to normal temporal experience. Ruth died peacefully in her sleep on November 30th, 2021, exactly as she had predicted. Her death was attributed to natural causes related to her advanced age and long-term institutional residence. In the months following Ruth's death, I began tracking the accuracy of her predictions. Linda Morrison, Margaret Chen, Thomas Rodriguez. Their death dates matched Ruth's statements exactly. Current staff members whose departure dates she had provided began experiencing the life changes she had described. Dr. Patricia Wong announced her retirement in March 2025, effective May 22nd, the exact date Ruth had specified. Michael Stevens transferred to a different facility in February 2028. Jennifer Adams left psychiatric nursing for a position in pediatrics in September 2024. I've documented Ruth's predictions in a private log, noting correlations between her statements and actual events. Her accuracy rate remains 100% for verifiable past information and appears to be maintaining the same precision for future predictions. My own date, October 7th, 2031, approaches as I write this account. I don't know whether that date represents my retirement, a career change, or something more final. But I've learned to trust Ruth's temporal observations, even as I can't explain how she acquired knowledge that exists outside normal human perception. Sometimes, silence isn't the absence of communication, and it's preparation for revelations that can only be shared when the timing aligns with purposes we don't yet understand. Ruth spent 34 years learning to see time from angles that psychiatric textbooks don't address, gathering information about futures that most of us can't access until they become our present. Her final gift was sharing that knowledge, providing us with glimpses of our own temporal trajectories while reminding us that human consciousness might be capable of much more than we assume when we limit ourselves to experiencing one moment at a time. During my second year of internal medicine residency at Mercy General Hospital, I learned that hospital geography can be more complex than architectural blueprints suggest. Corridors lead to wings that should be empty. Elevators stop at floors that are officially closed. And sometimes patient calls come from rooms that don't exist in the current hospital configuration. Room 309 taught me that some medical emergencies occur in spaces between official reality and something else entirely. It was 2:30 a.m. on a Thursday night in February when my pager buzzed with a patient call from room 309. The message was routine. Patient requesting physician evaluation. Urgent. I was covering the internal medicine service for the night shift, responsible for responding to any patient concerns that couldn't wait until morning rounds. I grabbed my stethoscope and headed toward the third floor, checking the hospital directory on my phone for room locations. According to the hospital map, room 309 was in the west wing of the third floor, an area I hadn't visited frequently during my residency. When I reached the third floor west wing, I found myself in a corridor I didn't recognize despite working at Mercy General for over a year. The hallway was dimly lit with older-style fixtures and paint colors that didn't match the recently updated decor throughout the rest of the hospital. The flooring was the vintage linoleum pattern that had been replaced hospital-wide several months earlier. Room 309 was at the end of the corridor, its door slightly ajar. Light spilled from the room, and I could hear the familiar sounds of medical equipment. Oxygen delivery systems, cardiac monitors, the quiet hum of hospital machinery. I knocked gently and entered the room. "I'm Dr. Peterson, responding to your call. How can I help you tonight?" The patient was an elderly woman, approximately 70 years old, lying in a hospital bed with nasal cannula oxygen. She appeared alert and oriented, though clearly distressed. The room was fully equipped with standard hospital furniture and monitoring equipment, all appearing functional and properly maintained. "Doctor, thank you for coming," she said, her voice clear but urgent. "I need to be discharged immediately. My family is waiting for me at home, and I can't stay here any longer." I approached her bedside, noting that she appeared medically stable despite her emotional distress. "What's your name, ma'am? Let me check your chart and see what we can do about your discharge request." "Elizabeth Morrison. I've been here far too long. The nurses keep saying I need to wait, but my grandson is getting married tomorrow, and I promised I would be there." I looked around the room for her medical chart or any documentation that would explain her admission and current treatment plan. The room appeared fully functional. Cardiac monitor displaying normal vital signs, IV pole with maintenance fluids, bedside table with standard patient amenities. "Mrs. Morrison, what were you admitted for?" "Do you remember what brought you to the hospital?" She looked confused for a moment, then shook her head. "I'm not entirely sure. I remember feeling short of breath, and then I was here. But I feel fine now, and I really need to go home." I attempted to access Mrs. Morrison's electronic medical record using the computer terminal in her room. The system showed no patient registered under that name, and no one was listed as occupying room 309. "Let me contact the nursing station to get your paperwork sorted out," I told her, reaching for the call button beside her bed. When I pressed the call button, nothing happened. No response light, no communication with the nursing station. I tried the room phone to call the nurses' station directly, but the line was dead. "I'll be right back," I told Mrs. Morrison. "I need to speak with the nursing staff about your discharge." I walked to the nurses' station for the third floor west wing and found it completely dark and unmanned. No computers, no patient charts, no staff members. The entire nursing station appeared to have been cleared out, as if the wing was no longer in active use. Confused, I returned to room 309 to find Mrs. Morrison still in her bed, but looking increasingly agitated. "Doctor, please," she said. "I've been waiting so long to go home. Can't you just sign my discharge papers?" "Mrs. Morrison, I'm having trouble accessing your medical records. Can you tell me who your attending physician is?" "Dr. Harrison has been taking care of me. He said I would be able to leave soon, but that was days ago." I didn't recognize the name Dr. Harrison among our current medical staff. "What's Dr. Harrison's first name?" "William Harrison. He's been very kind, but he seems busy with other patients." Dr. William Harrison had been a respected internist at Mercy General, but he had retired 15 years earlier and passed away in 2018. I decided to call security to help me understand what was happening in this apparently non-functional wing of the hospital. Using my cell phone, I contacted the main security desk. "This is Dr. Peterson. I'm in room 309 on the 3rd floor West Wing with a patient who needs assistance, but this entire area seems to be unmanned. Can someone come help me figure out the situation here?" "Dr. Peterson," replied Security Supervisor Tom Martinez. "The 3rd floor West Wing has been closed for renovations for the past 6 months. There are no patients in that area, and it's sealed off for construction work. I'm standing in room 309 right now with a patient named Elizabeth Morrison. She's on oxygen and requesting discharge. That's impossible. The entire West Wing is gutted for renovation. There's no power, no medical equipment, and definitely no patients. Tom, I need you to come to room 309 immediately. Something very unusual is happening here." "On my way." While waiting for security, I continued talking with Mrs. Morrison, trying to understand her situation and keep her calm. She provided detailed accounts of her hospital stay, mentioning specific nurses and doctors, describing meals she had been served, and referring to treatments she claimed to have received. "The night nurse. Sandra is usually here by now," Mrs. Morrison said. "She brings me warm blankets and helps me walk to the bathroom. Sandra Chen had been a night shift nurse on the medical floors, but she had died in a car accident 3 years earlier." Tom Martinez arrived at room 309 within 10 minutes, accompanied by 2 additional security officers. When they entered the room, their expressions shifted from professional concern to complete bewilderment. "Dr. Peterson," Tom said quietly, "what exactly do you see in this room?" "Mrs. Morrison in the hospital bed, oxygen equipment, cardiac monitor, standard room setup. Why?" Tom walked around the room, apparently looking at something completely different from what I was observing. "This room is completely empty, stripped bare. No bed, no equipment, no patient." I looked at Mrs. Morrison, who was watching our conversation with growing concern. "Tom, she's right there in the bed. Can't you see her?" "Dr. Peterson, I need you to step into the hallway with me." I followed Tom outside room 309, leaving Mrs. Morrison temporarily alone. In the hallway, Tom explained what he and his team were observing. "The room is empty, Doctor. Concrete floors, bare walls, no electrical connections. The entire West Wing was cleared out 6 months ago for major renovation work. There's been no power to this area since August. But I can see her clearly. The equipment is functioning. The lights are on. She's talking to me. We need to get you checked out by the emergency department. This could be a medical issue. Fatigue, blood sugar, medication reaction." I insisted on returning to room 309 to check on Mrs. Morrison one more time. When I entered, she was sitting up in bed, looking directly at me with an expression of sad understanding. "You can't help me, can you?" she said softly. "Mrs. Morrison, I'm trying to understand your situation." "Can you tell me what year you think it is?" 1987, she replied without hesitation. "What's the last thing you remember before being in the hospital?" Mrs. Morrison looked thoughtful. "I was getting ready for my grandson's wedding. I couldn't breathe very well, and my daughter called an ambulance. But the wedding was supposed to be the next day, and I've been here so long now." I realized that Mrs. Morrison wasn't a current patient. She was somehow connected to the hospital's past, possibly a patient who had died decades earlier but remained in some form of temporal displacement, continuing to experience her hospitalization in a space that existed between the hospital's former configuration and its current reality. "Mrs. Morrison," I said gently, "I think your grandson's wedding has already happened. You've been resting for a very long time." She nodded slowly. "I've been waiting for someone to explain that to me. The other doctors and nurses, they all seem so busy, and they never have time to answer my questions properly. Are you ready to go home now? To leave the hospital and join your family?" "I think so," she said. "I've been ready for a long time, but I didn't know how to complete the discharge process." Mrs. Morrison lay back in her bed and closed her eyes. "Thank you, Doctor." Thank you for helping me understand. When I looked again, the bed was empty. The room appeared exactly as Tom Martinez had described. Bare concrete floors, stripped walls, no medical equipment. Mrs. Morrison had simply departed. I spent the rest of that night researching hospital records from the 1980s. Elizabeth Morrison had indeed been a patient at Mercy General in October 1987. She had been admitted with congestive heart failure and pneumonia, treated by Dr. William Harrison. She had died on October 15, 1987, while waiting for her grandson's wedding, which had been scheduled for the following day. Room 309 had been her room during that final hospitalization. The West Wing renovation was completed 4 months later. Room 309 was converted into a family conference room, and the space was redesigned with modern equipment and updated decor. But I sometimes walk past that area and wonder if other patients from the hospital's past remain in temporal displacement, continuing their hospitalizations in spaces that exist between architectural reality and the persistent memory of institutional care. Mrs. Morrison taught me that discharge planning sometimes involves helping patients transition not just from sickness to health, but from one form of existence to another. Some patients require assistance letting go of medical care itself, understanding that their need for hospital services has transformed into something beyond the scope of conventional medicine. I've learned to pay attention when patient calls come from areas of the hospital that shouldn't be operational, because sometimes the most important medical consultations occur in spaces between what the hospital was and what it has become, serving patients whose needs transcend the boundaries of normal temporal experience. I've been working as a family physician at Westside Community Clinic for 13 years, maintaining a busy practice that serves approximately 1,200 active patients. My schedule runs with predictable efficiency: routine checkups, chronic disease management, acute illness visits, and preventive care appointments. Each patient interaction is documented meticulously, with careful attention to appointment times, treatment plans, and follow-up scheduling. The case of Robert Fleming challenged everything I understood about the finality of death and the boundaries of medical practice. Robert had been my patient for 8 years, a 69-year-old retired accountant with well-controlled diabetes and hypertension. He was compliant with medications, attended regular appointments, and maintained good relationships with my staff. His medical care was routine and uncomplicated, the kind of straightforward case that forms the backbone of family medicine practice. On Tuesday, October 5th, Robert failed to show up for his scheduled 2:30 p.m. appointment. This was unusual, as he rarely missed appointments and always called if he needed to reschedule. When my receptionist, Linda Martinez, called his home number, there was no answer. The following week, Robert's daughter called to inform us that her father had passed away unexpectedly on October 3rd from a massive heart attack at his home. She thanked us for his years of care and requested copies of his medical records. For estate purposes, I was saddened by Robert's death but not surprised. Sudden cardiac events are unfortunately common in his demographic. Despite good medical management, I completed his final chart notes, documented the date and cause of death, and closed his active patient file according to our standard protocol. 2 weeks after Robert's death, on October 19th, I found an appointment scheduled in my calendar for 10:30 a.m. Robert Fleming, follow-up visit, medication review. I assumed this was a scheduling error, possibly a recurring appointment that hadn't been properly canceled after his death notification. I asked Linda to remove the appointment and verify that Robert's file had been appropriately updated with his death information. Dr. Williams, Linda said, checking our scheduling system, I didn't schedule this appointment. According to our logs, it was added yesterday evening after clinic hours, but there's no record of who made the entry. Could Robert's family have called and somehow gotten scheduled without realizing he had passed away? I spoke with his daughter personally 2 weeks ago. She definitely knows about his death, and she hasn't contacted us since then. Despite the confusion, I left the appointment slot open, planning to use the time for administrative tasks. At exactly 10:30 a.m., Linda buzzed my office. Dr. Williams, Robert Fleming is here for his appointment. I assumed she was mistaken. Perhaps another patient with a similar name, or someone asking about Robert's medical records. Linda, Robert Fleming died 2 weeks ago. I know that. she replied, her voice sounding uncertain. But he's sitting in the waiting room right now, and he says he has an appointment with you. I walked to the waiting room and found Robert Fleming sitting calmly in his usual chair, wearing the same type of conservative button-down shirt and slacks he always wore to appointments. He looked exactly as I remembered. Same facial features, same posture, same quiet demeanor. "Robert?" I said, approaching him carefully. He looked up and smiled. "Good morning, Dr. Williams. Thank you for fitting me into your schedule. I know this is an unusual situation." I stared at him, trying to process what I was seeing. This was unquestionably Robert Fleming. Same voice, same mannerisms, same polite formality he had maintained throughout our 8-year doctor-patient relationship. "Robert, I received word that you had passed away on October 3rd. He nodded calmly. "That's correct. I did die on October 3rd at approximately 6:45 a.m., but I needed one final appointment to complete some medical business." "What kind of medical business?" "I need to review my medications, update my health directives, and receive some test results that weren't available before my death." "Could we proceed with the appointment?" Against every rational instinct, I led Robert to examination room 3, the same room where I had conducted his appointments for years. He sat on the examination table with the same patience he had always shown, waiting for me to begin the consultation. "Robert, I need you to help me understand what's happening here." "Are you alive?" "I'm present for this appointment," he replied diplomatically. Whether that constitutes being alive in the conventional sense is a more complex question. I decided to proceed with a standard physical examination, curious to see what I would find. Robert's vital signs were normal: blood pressure 128/78, pulse 72, temperature 98.6, respiratory rate 16. His physical examination revealed no abnormalities, no signs of illness or distress. "How do you feel?" I asked, completing the routine assessment. "Very well, thank you. Better than I've felt in years, actually. Death has been quite restorative." I pulled up Robert's electronic medical record on the examination room computer. His file showed the death notification from 2 weeks earlier, but it also contained new entries that I hadn't seen before. Laboratory results dated after his death, medication adjustments, and updated health assessments. "Robert, according to your chart, you had blood work done on October 10th. That was a week after you died." He looked at the computer screen with mild interest. "Yes, I needed to complete some routine monitoring. My diabetes management required adjustment, and I wanted to ensure my cholesterol levels were optimized. But you're dead. Dead people don't need diabetes management." Robert considered this thoughtfully. "Death doesn't immediately resolve all medical concerns. There's often a transition period where ongoing health maintenance remains important." I printed out the laboratory results from October 10th. The blood work had been drawn at our clinic's laboratory, processed normally, and resulted with Robert's name and date of birth. His hemoglobin A1C was perfect, his lipid panel was within ideal ranges, and his kidney function was excellent. "These are the best lab values you've ever had," I observed. "Death has been very therapeutic for my chronic conditions," Robert agreed. I spent 30 minutes reviewing Robert's medical history, discussing his medications, and updating his health directives according to his requests. He was knowledgeable about his medical conditions, articulate about his treatment preferences, and engaged in the appointment exactly as he had been during his living visits. "Is there anything else you need from this appointment?" I asked. "Just the usual paperwork," Robert replied. "I'd like copies of today's visit notes and my updated medication list." I prepared his discharge summary and printed the requested documents. Robert reviewed them carefully, signed the medication reconciliation form, and stood to leave. "Thank you, Dr. Williams. This completes my medical care requirements. I don't anticipate needing any further appointments." Robert walked calmly to the reception desk, where Linda processed his checkout with the same professional routine she used for all patients. He signed out at exactly 11:15 a.m. and left the clinic through the main entrance. After Robert's departure, I immediately called his daughter to inquire about the situation. She confirmed that her father had been buried on October 8th and that no family members had any contact with our clinic since his death notification. I requested security footage from our clinic cameras for October 19th. The video clearly showed Robert Fleming entering the clinic at 10:25 a.m., sitting in the waiting room, following me to the examination room, and leaving through the main entrance at 11:15 a.m. The timestamp on Robert's death certificate, which I retrieved from county records, listed his time of death as 11:15 a.m. on October 3rd, exactly the same time he signed out from his final appointment 16 days later. I've documented this encounter in Robert's medical file, noting the impossible nature of providing medical care to a deceased patient. The laboratory results from his post-death blood work remain in our system, showing optimal health parameters that he never achieved while living. 6 months later, I received a letter addressed to Dr. Williams from Robert Fleming. The postmark was local, dated 3 days after I received it. The letter thanked me for years of excellent medical care and explained that his final appointment had been necessary to close the loop on unfinished medical business. Some patients, the letter concluded, require one final consultation to transition completely from medical care to whatever comes next. Thank you for accommodating this unusual request. I've kept Robert's letter in his medical file, along with documentation of his impossible final appointment. Sometimes the most important medical consultations occur after conventional treatment is no longer possible, providing closure that patients need to complete their transition from life requiring medical intervention to whatever form of existence follows. Robert Fleming taught me that death doesn't always end the doctor-patient relationship immediately. Sometimes it transforms it into something that serves different purposes while maintaining the same fundamental commitment to healing and care. I've been a clinical pharmacist at Metropolitan General Hospital for 19 years, processing thousands of prescription orders from physicians throughout our medical center. Electronic prescribing has streamlined the medication ordering process, providing clear documentation of prescriber identity, patient information, and medication details. The system maintains detailed logs of when prescriptions are entered, by whom, and from which computer terminal. The prescription that arrived for Patricia Reynolds on March 15th violated every security protocol in our electronic system while potentially saving a patient's life through impossible means. The order appeared in our pharmacy queue at 3:47 a.m. Patricia Reynolds, patient ID 847293, medication, Cinacalcet 30 mg, PO bid, prescriber, Dr. Michael Chen, endocrinology department. The prescription included proper patient identifiers, appropriate dosing instructions, and valid electronic signature authentication. What made this prescription problematic was that Dr. Michael Chen was on vacation in Thailand, scheduled to return the following week. According to our system logs, the prescription had been entered from his office computer, but security confirmed that his office had been locked and unoccupied since his departure 10 days earlier. I called Dr. Chen's emergency contact number to verify the prescription, assuming there might be coverage arrangements I wasn't aware of. The call went directly to voicemail. Not unexpected, given the time zone difference and early morning. Aunt Patricia Reynolds was a 56-year-old woman admitted 3 days earlier with severe hypercalcemia, dangerously elevated calcium levels that were causing confusion, kidney problems, and cardiac rhythm disturbances. Her condition was puzzling because standard treatments weren't providing adequate calcium reduction, and her underlying cause hadn't been clearly identified. Cinacalcet is a specialized medication used to treat specific types of hypercalcemia, particularly those related to parathyroid disorders. It's not a first-line treatment and requires careful consideration of the patient's specific calcium metabolism dysfunction. I reviewed Patricia's chart to assess whether Cinacalcet was appropriate for her condition. Her laboratory values showed the exact pattern of calcium, phosphorus, and parathyroid hormone levels that would respond well to Cinacalcet therapy. The prescription dosing was perfect for her body weight and kidney function. This was precisely the medication Patricia needed, ordered by the one physician in our hospital most qualified to prescribe it for her specific condition, sent from his locked office while he was on another continent. I contacted Dr. Jennifer Martinez, the overnight medicine attending, to discuss the suspicious prescription circumstances. The medication order is clinically appropriate, Dr. Martinez agreed after reviewing Patricia's case. Cinacalcet could be exactly what we need to control her calcium levels. But the prescriber authentication issues are concerning. Should we hold the medication until we can verify Dr. Chen's authorization? Dr. Martinez looked at Patricia's latest laboratory results. Her calcium is still critically elevated despite maximum standard therapy. If cinacalcet is going to help, we need to start it soon. We decided to proceed with the medication while documenting the unusual circumstances and planning to verify the prescription with Dr. Chen upon his return. Patricia's response to cinacalcet was remarkable. Her calcium levels began normalizing within 12 hours, her mental status cleared, and her kidney function improved significantly. The medication provided exactly the therapeutic effect needed for her specific type of hypercalcemia. Dr. Chen returned from vacation on March 22nd. I contacted him immediately to discuss the mysterious prescription he had apparently sent while overseas. I didn't send any prescriptions. While I was on vacation, Dr. Chen said initially, I was completely disconnected from hospital systems for 10 days. I showed him the electronic prescription record, including his authentic digital signature and the timestamp showing entry from his office computer. This is definitely my electronic signature, he confirmed. But I have no memory of sending this prescription, and I certainly wasn't in my office at 3:47 a.m. on March 15th. Could someone else have access to your computer and prescribing credentials? Impossible. My office was locked, and my electronic signature requires biometric authentication that only I can provide. Dr. Chen reviewed Patricia's case and confirmed that cinacalcet had been the optimal treatment choice for her specific condition. This is exactly what I would have prescribed if I had been consulted about her case, he said. The dosing is perfect, the timing was critical, and it appears to have been life-saving therapy. 3 days later, Dr. Chen contacted me with additional information about the mysterious prescription. I need to tell you something unusual, he said. I've been thinking about that prescription date and time, and I remember having a very vivid dream during my vacation. What kind of dream? I dreamed I was in my office, reviewing a patient case, a woman with severe hypercalcemia that wasn't responding to standard treatment. In the dream, I calculated the appropriate cinacalcet dosing and entered a prescription into our electronic system. When did you have this dream? Dr. Chen checked his travel journal. March 15th, early morning. I woke up around 4 a.m. local time, which would have been 3:47 a.m. here, thinking about calcium metabolism disorders. The dream was so realistic that I almost called the hospital to check if we had any hypercalcemic patients. Are you saying you think you somehow sent a prescription while dreaming? I know how impossible that sounds, but the timing matches exactly. And the clinical scenario in my dream was identical to Patricia Reynolds' actual case. I investigated whether there were any technical explanations for the prescription entry. Hospital IT security reviewed Dr. Chen's office access logs, computer login records, and network connections. Their findings were definitive. No unauthorized access to Dr. Chen's computer or prescribing system occurred during his vacation. Period. The prescription was entered using proper authentication from Dr. Chen's authorized computer terminal, reported IT security. All digital signatures match his biometric profile, and the system shows no evidence of tampering or unauthorized access. Could the prescription have been entered before his vacation and somehow delayed in transmission? The system doesn't have delay capabilities for prescription orders. Everything is processed in real time, and our logs show the prescription was created and transmitted at 3:47 a.m. on March 15th. I documented the entire incident in our pharmacy's unusual occurrence reports, noting the impossible circumstances and the positive patient outcome. Patricia Reynolds made a complete recovery, and her hypercalcemia resolved entirely with cinacalcet therapy. 6 weeks later, I encountered a similar situation. Dr. Sarah Wong, who was attending a conference in Europe, apparently sent a prescription for a rare antibiotic needed for a patient with an unusual infection. The medication order arrived electronically during her flight, when she would have had no internet access. When I contacted Dr. Wong after her return, she described having a dream during the flight about treating a patient with exactly the infection pattern we had encountered at the hospital. I dreamed I was prescribing vancomycin, with specific dosing adjustments, for a patient with MRSA endocarditis, she told me. The dream was so detailed that I made notes about it in my travel journal. The prescription she had dreamed was perfectly appropriate for the patient we were treating, with dosing calculations that required expert knowledge of the antibiotic's pharmacokinetics. Over the past 2 years, I've documented 12 cases of physicians sending prescriptions while sleeping, traveling, or otherwise unable to physically access our computer systems. Each prescription was clinically appropriate, properly authenticated, and provided optimal therapy for patients with urgent Medical needs. The phenomenon seems to occur most frequently when patients have rare conditions, requiring specialized medications that only specific physicians would know to prescribe. The prescriptions arrive precisely when needed, with perfect dosing and timing, as if generated by medical expertise that operates beyond the constraints of physical presence or conscious awareness. I've theorized that some physicians develop such deep expertise in their specialties that their knowledge becomes accessible through non-conscious channels when patients need their specific skills. The electronic prescribing system somehow captures this expertise and translates it into appropriate medication orders. Dr. Chen continues to receive dream prescriptions occasionally, always involving complex endocrinology cases that require his particular expertise. He's learned to trust these unconscious clinical decisions, recognizing that his medical knowledge operates more effectively during sleep than his conscious mind might assume. Maybe medical training creates neural pathways that remain active even when we're not consciously practicing, he suggested. Perhaps the electronic systems are tapping into medical expertise that exists at subconscious levels. I've learned to appreciate mysterious prescriptions that arrive through impossible means, especially when they provide exactly the therapy that patients need at critical moments. Sometimes the most important medical orders come from physicians who aren't physically present, but whose expertise transcends the boundaries of location, time, and conscious awareness.